Good afternoon, everybody. My name is Alan Bell. I'm a family physician in Toronto and Vice President of Thrombosis Canada. It's my privilege this afternoon to welcome you all here and to host this presentation on thrombosis and COVID-19, a Canadian expert perspective on behalf of Thrombosis Canada. I would like to start off today's presentation by thanking all of the frontline workers who have helped to protect us during this pandemic. And by that, I mean not only healthcare professionals, but grocery store workers and all of the other essential services that are in fact putting themselves on the line to protect us all. And in fact, I would like to take a moment just to thank all Canadians. I think that what we have seen in Canada with regard to COVID-19 has been impressive when we compare it certainly to the rest of the world. I think that we need to congratulate all Canadians for respecting social distancing and other measures that have been brought forward in order to flatten the curve. And I think we really have seen the curve flattened. We have not seen our greatest fears. We haven't seen our emergency rooms, our hospital wards, our intensive care units overrun. And I think for that, we need to thank all Canadians. Thank you. So I'd like to thank, first of all, our planning committee, who you see on the screen in front of you, who have very generously dedicated their time to making this program the success that it is. This is our second presentation. I welcome back all of the individuals who attended our first one for any updates that we can provide to you today, and of course to all the new participants within this program. Thank you. These are the disclosures for the individuals who you will be seeing presenting today. I'll just leave that up on the screen for you a moment to have a look at. I would also like to disclose that we have received commercial support from this. Thrombosis Canada has received an unrestricted educational grant from the following commercial organizations: Bear Canada, Bristol Myers Squibb Pfizer Alliance, Leo Pharma, Novartis Pharmaceuticals Canada, Pfizer Canada, as well as Servier Canada. So thank you to all of our sponsors. I would also like to point out that the agenda and faculty of this program was developed by the Scientific Steering Committee from Thrombosis Canada. All faculty have been directed that any recommendations involving clinical medicine are to be based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in this program in support or justification of patient care recommendation conforms to the general accepted standards. I would also like to state that at no time prior to this presentation did any sponsors have any input to or even be privy to any of the content of this program. So what are our objectives today? Obviously, our objectives are to try to bring you up to speed with the very rapidly changing information regarding COVID-19 and thrombosis, which is literally changing on a daily basis as new publications become available to us. And in fact, will continue to change probably over the next few years. And we want to also not just talk to you about the important aspects directly related to COVID-19, but for our primary care and non-hematology and non-intensivist individuals, we want to help you effectively manage anticoagulation and thrombosis from this very new world that we're all practicing from, either virtually or by telephone, but in some form, generally speaking, remotely. And of course, we wanted to discuss and explain to you some of the hematologic complications, specifically coagulopathic issues that are associated with COVID-19. This is our agenda. We will run approximately 1 hour for the presentations, and we have 30 minutes also allotted for your questions and answers program. There's a lot of you on this presentation today, so I don't know that we'll get to all of your questions, but what I do promise you is that your questions will be addressed on the Thrombosis Canada website in our frequently asked questions section. We have posted questions from the previous session, and we'll continue to post questions that come up today. So please enter them in the chat function as we go along. There's just too many of you on this program to allow you to ask your questions directly. So I've been asked to speak to you a little bit about primary care perspective with regard to thrombosis and COVID-19. In primary care, it's certainly been, shall I say, turned on its ear by the COVID-19 pandemic. I can't think of any time in the past where I've been forced to close my waiting room, where I've been only allowing patients to come into my office one at a time and having to call from the parking lot in order to see me. It's been a very bizarre world indeed. So these visits that I actually do get to see patients are actually few and far between. And as I mentioned earlier, the vast majority of the patient encounters that I am having are either virtually or by telephone. And the management of specific thrombotic issues by telephone raises its own challenge. Certainly, it's always very helpful to be able to do a detailed examination of patients who are presenting with, for example, venous thromboembolism, and we just don't have that luxury frequently in the present environment. We also, are trying to restrict sending our patients to emergency departments. Although the emergency departments are surprisingly not overrun, as you will hear from from Dr. Lang, our emergency physician today, we still want to keep patients, I think, out of the hospital environment because of the potential source of COVID-19 exposure that they may see there, just in the principles of social distancing. INR monitoring is a real question. Do our patients really have to come in every month to get INR testing if they're on warfarin? How do we manage elevated INRs remotely? Do we need to see these patients? Do we need to refer them to the emergency department? And COVID-19 infection itself, as primary care physicians, we certainly are seeing these patients who are presenting with outpatient presentations of COVID-19, and we need to be aware, as from a primary care perspective, that there are indeed thrombotic as well as bleeding complications associated with this infection. Now, I would love to say that I'm going to walk you through how to manage all of these conditions virtually, but I don't have to. And the reason that I don't have to is because at Thrombosis Canada, we've been dedicated to providing guidance on the management of thrombotic disorders, point of care guidance that you can use from our website. And I believe that in this time of COVID-19, when we are not having the luxury of seeing our patients directly and having to manage them virtually, that this resource is particularly valuable now. It's been a long time that I have been promoting to my colleagues in primary care the importance and frankly the ease with which many thrombotic conditions like venous thromboembolism, particularly DVT, can be managed as an outpatient. And in order to provide guidance on how to do that, I refer them to the Thrombosis Canada assets that we have worked so hard on and continually update on a regular basis. And by that, I'm referring to, first of all, the Thrombosis Canada clinical guides. If you have questions regarding thrombotic conditions, these provide a tremendous resource for any generalist or pharmacist or any healthcare professional to assess their patients using point of care guidance. Really a simple process. We currently have 49 guides available on our website that are updated annually. You won't find anything on this website that is out of date. Furthermore, we provide you with tools that will assist you in the guidance of venous thrombotic disorders. So, for example, deep vein thrombosis. The vast majority of patients with DVT can be managed as outpatients and do not need to attend hospital emergency rooms. There's a principle that has been put forward for a good number of years now, that if you are suspicious and you think there is a high probability of a patient having a DVT, a deep vein thrombosis, then the approach is to treat that patient first and subsequently do investigations to rule it out. So, these are important conditions to treat quickly. Thrombosis Canada can provide you with the tools that you need and the guidance that you need through our website to assist you in that management, and I encourage you to use them. We also have very specific clinical resources dedicated to COVID-19. You will see on this the answers to Q&A that you have presented from previous sessions that we have done like this, as well as from the session that we are doing today, as well as general principles around thrombotic issues associated with COVID-19. So with that introduction, I would like to introduce our first speaker of the day, Jim Duquetis. Jim is professor in the Division of Hematology and Thromboembolism in the Department of Medicine at McMaster University. He is a staff physician at St. Joseph's Hospital in Hamilton and is the president of Thrombosis Canada. So to provide you with an internist perspective, Jim.
Thank you very much, Alan. Good afternoon or good morning, everyone. My task in the next 4 or 5 minutes is to set the table, so to speak, by providing you with an overview of COVID-19, discussing briefly its pathophysiology, diagnosis, clinical features, and treatment. Now, I know there's been a lot of interest about treatment options, and I can tell you, at least as of this morning, that I'm not aware of any completed randomized studies that have assessed treatment, whether antithrombotic or otherwise, but I can share with you through connections and colleagues that this is an intense area of investigation. This is some information that is rather germane and I'm sure very familiar to you as regard the etiology, epidemiology of COVID-19 and some of the emerging and established risk factors for COVID-related adverse outcomes. In terms of the pathophysiology, there is emerging evidence indicating that not only does the virus use the lung angiotensin-converting enzyme inhibitor 2 as a receptor to initiate an inflammatory response within the lung. But there's also emerging evidence that in fact ACE receptors, which are located on endothelial tissue throughout the body and multiple organs, may lead to viral endothelial invasion, endotheliitis, and this may precipitate vascular injury and in turn thrombosis. So this is very interesting information that I think is driving our therapeutic strategies. Below you see some of the data on incubation and period of contagious for the virus. This is some information about the diagnosis. One thing I think to highlight, which I'm sure many of you know, is that the tests we have are very sensitive, close to 100, if not 100%, but not, are very specific, sorry, close to 100%, but not very sensitive. So the implication being that a negative test or even 2 negative tests may not necessarily exclude a diagnosis of COVID-19. So the clinical suspicion remains of paramount importance. And here are some of the clinical and radiologic features that, again, we are all familiar with. The X-ray shows an emerging interstitial pattern, a more advanced presentation with ground glass appearance on the CT scan, and not to forget that we can be dealing with non-COVID related diseases, and that those should be equally important and on our radar. Next slide. And finally, in terms of the treatment, of course, we are all familiar with the general supportive treatment that is considered for these patients. And as I alluded to, ongoing randomized trial investigations looking at anti-inflammatory, antiviral, IL-2 pathway inhibitors, blood product related management, and as will be discussed by Dr. Tseng and others, the use of anticoagulants as we are seeing that COVID-19 is in fact a hypercoagulable disease. The website there by the National Institute of Health provides a nice summary of ongoing and planned clinical trials. So with that, I'm going to hand it over to Dr. Tseng, and I hope you really enjoy the rest of this webinar.
So as Jim mentioned, our next speaker is Dr. Eric Sang. Dr. Sang is a hematologist and assistant professor in the Division of Hematology and Oncology at the University of Toronto. He's a staff hematologist at St. Michael's Hospital. Eric?
Thanks, Alan and Jim. Thanks for everyone for joining us for today for this second webinar with Thrombosis Canada about COVID-19. So my section is going to focus on the hematology and coagulation issues. As Jim had discussed, this is a hypercoagulable state, and there is emerging evidence on the coagulation issues and antithrombotic issues. But this is also to highlight what we know and what we don't know so far. And as Jim mentioned, this is an area of intense academic interest with many clinical studies that are ongoing or about to get started in the near future. So this is my first slide and my last slide. The main messages from my section will be as follows. Number one, severe COVID infection is a hypercoagulable state with emerging data for high VTE incidence, particularly in critically ill patients, in the presence or the absence of pharmacological thromboprophylaxis. Secondly, it's true that elevated D-dimers are very commonly seen, especially in patients who are critically ill with COVID-19. But at the moment, it still remains unclear if the high D-dimer reflects hypercoagulability or if it's merely a marker of the pro-inflammatory response because it's an acute phase reactant. Thirdly, all admitted COVID patients should receive standard weight-adjusted VTE prophylaxis. However, there is insufficient data at this time to recommend intensified either intermediate or therapeutic prophylaxis regimens for specific populations, including those with high D-dimer, those who are vented in the ICU outside of the clinical trial setting. Next slide. So this slide summarizes the common hematology abnormalities that we see in COVID-19. On the left are the parameters, in the middle is the trend, and then in the right is the clinical significance that we know of so far. So as you know, many patients who are critically ill will develop thrombocytopenia. The thrombocytopenia that we have been seeing in COVID-19 tends to be mild to moderate, with a platelet count in the 100 to 150 range, as opposed to the severe thrombocytopenia that we see with other more consumptive forms of DIC. And this has not been shown to be associated with mortality. It's a very commonly associated finding that we see lymphopenia, with up to 80% of people having a mild lymphopenia. The severe lymphopenia with an ALC, absolute lymphocyte count of less than 0.5, is typically seen in patients who are critically ill. We're also seeing prolongations, especially in the prothrombin time. These tend to be relatively mild, and they do carry some prognostic significance. The D-dimer, however, the fourth row there, has had a lot of intense interest, and we're seeing, particularly in critically ill patients, that we often see marked elevations 4 to 6 times the upper limit of normal, and these are also prognostic and associated with non-survivors. Finally, the fibrinogen, as you know, in other forms of DIC, consumptive forms, we tend to see hypofibrinogenemia with a fibrinogen of less than 1.0. Typically with COVID-19, the fibrinogen actually remains elevated until quite late in the disease course. And we will see on the next slide that as you get further into the admission, patients who do not do well often develop hypofibrinogenemia. Next slide. So the headline is at the top here. COVID-19 does have some features of DIC. However, at the moment, it looks to be more of a procoagulant phenotype rather than a consumptive coagulopathy. So as an example, the data on the left-hand side here is early data from Wuhan looking at patients who had coagulation parameters checked on admission. In yellow are the parameters that were statistically significant between survivors and non-survivors. So you're seeing, as we mentioned previously, that the prothrombin time and the D-dimer are both prolonged or elevated more so in non-survivors than in survivors, whereas the PTT and the fibrinogen are not as markedly different. On the right, you will see graphs. Looking at the top is D-dimer and the bottom is fibrinogen concentration. And in the green are the patients who survived. and in the blue are the patients who did not survive, and in the blue are the patients who did survive, and the x-axis is days after admission. So we're seeing here with the D-dimer, for example, that as these patients who did not survive get later into their disease course, the D-dimer continues to rise. Whereas with the fibrinogen concentration, we're seeing that initially survivors and non-survivors have elevated fibrinogen concentrations, but as you get further into the disease course in non-survivors, the fibrinogen level does decrease as they get more ill. Other data from Wuhan, 1,100 patients who were presented with COVID, 46% had a D-dimer on presentation. This included patients who had severe disease, but also very mild disease. And amongst the patients who eventually were intubated or required ICU admission, 70% of these patients had an elevated D-dimer on admission, indicating that the D-dimer can be an early prognostic sign in these patients. And in fact, the ISTH guidelines would suggest that the D-dimer should be one of the tests that you measure on admission for patients who present to hospital. Next slide, please. So it's true that these patients often have an elevated D-dimer, but the significance of this is uncertain. This may reflect a hypercoagulable state, but this may also reflect the underlying inflammatory state. There have been several studies published in the past 2 weeks looking at coagulation parameters, also some studies looking at thromboelastography, for example. These studies have suggested that all of the typical coagulation parameters that are associated with acute phases and inflammation are also elevated in patients who have severe COVID. So this would be high D-dimers, high fibrinogen concentrations, factor 8, von Willebrand factor. These are all elevated, but again, it's unclear to what extent they are associated with thrombosis and with prognosis overall. Again, because these are all non-specific acute phase reactants, the D-dimer can also be elevated in patients who have non-COVID related pneumonia and other causes of SIRS or sepsis. So the data in this table presented below is an example of this. This is a study that was also taken from China, looking at 550 patients who were admitted with pneumonia. 450 had COVID-related pneumonia, but 100 had non-COVID related pneumonia. And at the bottom on the last row is the D-dimer highlighted in yellow. And you're seeing here that the D-dimer is elevated significantly so, regardless of whether the patients had COVID or non-COVID related pneumonia. Again, demonstrating the fact that the D-dimer is a relatively non-specific marker at this time. Next slide, please. However, as Jim mentioned earlier, it's becoming apparent that severe COVID is a hypercoagulable state, and that the high D-dimers and fibrinogen are a marker of this to some extent. There have been several pathologic studies now showing evidence of pulmonary microvascular thrombosis. However, these findings may also be seen in non-COVID related ARDS. And so the questions that are raised by these autopsy studies are interesting. To what extent does the microvascular thrombosis contribute to the hypoxemic respiratory failure that we're seeing in these patients? And the big question that remains unanswered is, could anticoagulation therapy and at what intensity affect the overall disease course? So I presented two case series here that have looked at these findings in pathological studies. One is from Fox from New Orleans. They looked at 4 patients who had COVID-related ARDS. And in addition to diffuse alveolar damage, there was evidence of thrombosis in the small vessels with associated focal alveolar hemorrhage. Dolnikoff also published a study last week from Sao Paulo looking at 10 lung biopsies, and they found very similar findings: diffuse alveolar damage and markers of increased local procoagulant effect with megakaryocyte activation and a variable number of fibrinous thrombi in the small pulmonary arterioles. Next slide, please. In patients who don't receive pharmacologic prophylaxis, it's become clear that they have high incidence or prevalence of VTE. This was an early study from China looking at 81 patients who were admitted to their ICU. None of them received pharmacologic prophylaxis, and they all were screened with a leg ultrasound and a D-dimer. The CT test was also done not as a pulmonary angiogram protocol, but as to look at the evidence of lung disease. In these patients who did not receive pharmacological prophylaxis, 25% had evidence of lower extremity DVT. The D-dimer cutoff of 1500 in these patients had a reasonable sensitivity and specificity for the presence of VTE as well in these patients. But again, this would not reflect our standard of care in Canada, wherein critically ill patients typically receive pharmacological prophylaxis. Next slide, please. These are two additional studies looking at VTE rates in ICUs in COVID patients, despite mostly standard VTE prophylaxis doses. So on the left is a study from Helms in France. They looked at 150 ICU patients. The anticoagulant regimen is in the first box. 80% received standard prophylaxis, which there would be a type of low molecular heparin at 4,000 units daily, or they used a very low dose of IV heparin. This would be less than half of a typical infusional rate for therapeutic dosing. 20% of patients also received therapeutic dose anticoagulation. The reasons for why they received therapeutic dose empirically were not entirely clear. Of note, over 95% of these patients had an elevated D-dimer and fibrinogen, and they did not screen with ultrasounds for DVT. These patients, despite VTE prophylaxis, had high rates of thrombosis, so 17% had pulmonary embolism. Of the patients who were on renal replacement therapy, 28 out of 29 had some evidence of circuit clotting, and some of the patients on ECMO also had a thrombosed centrifugal pump as well. And of the patients who had ARDS, when they looked back at, again, patients during that time who had COVID versus non-COVID ARDS, the prevalence of pulmonary embolism was higher in the COVID group. The CLOC study from Netherlands was one of the first case series published, 184 patients in their ICUs. Most of them received routine pharmacological prophylaxis, and then after a certain time, March 30th or April 4th, many of them were escalated to an intermediate dose with a slightly higher dose if they were greater than 100 kilograms. 9% did receive therapeutic dose anticoagulation at baseline. These patients were quite sick. 38% had evidence of coagulopathy with long clotting times. 13% were on renal replacement therapy. And again, these patients were not screened with ultrasound for VTE. And if you looked at the cumulative incidence of thrombosis, it was very high. It was 31%. This was reported as a cumulative incidence because at the time, several patients were still admitted to hospital. Of note, some of the events here were events that we would not typically report as outcomes in many VTE studies. So there was 7 subsegmental pulmonary emboli, and some patients had stroke as well. Next slide, please. This is another study from the Netherlands again. This was one hospital from reported by Saskia Middeldorp, 198 hospitalized Dutch patients, of whom 74 were in the ICU. The ICU patients in general had a higher D-dimer and on admission. A small percentage had evidence of prior VTE or active cancer, and 9% were on therapeutic anticoagulation. In this study, the patients received standard prophylaxis with an adjustment for weight above 100 kilograms. However, after April 30th, there was an empiric increase to an intermediate dose in patients who were admitted to ICU. And so the dose presented here is what they used. They used nadroparin at a BID dose, and then the BID dose was doubled if the patients were above 100 kilograms. They also, partway through the study, began screening with ultrasounds in the ICU because they started noting an increased prevalence of VTE. And again, like some of these other studies, these patients, at the time that this was published, many were still hospitalized, but 14% had passed away. The outcomes were as follows. In the ICU patients, they noticed that there was a higher cumulative incidence of VTE than patients who were on the medical inpatient wards, despite the use of prophylaxis at the doses that I mentioned previously. The cumulative incidence at 7 days for all VTE events was 25%, and for symptomatic VTE, it was also around that as well. And we're seeing at 14 days even higher rates than that. Risk factors for VTE included the high D-dimer and also evidence of lymphopenia. In the patients who were not in the ICU, the cumulative incidence was reported as 6.5% for any VTE, or 10% at 14 days. Next slide, please. This is another well-known study that was published a few weeks ago now. This was a study from China where they looked at patients who had severe COVID, 450 of them. These patients received a variable prophylaxis regimen. Most of them didn't receive anything, but 22% did receive VTE prophylaxis with inoxaparin, either at 40 milligrams or at 60 milligrams, which would be more of an intermediate dose, or subcutaneous and fractionated heparin, but that was the minority of patients. And they looked at mortality at 28 days in a retrospective study. There was no difference in mortality between the heparin and non-heparin users, but patients who had an elevated D-dimer above 6 times the upper limit of normal, or who had evidence of significant coagulopathy with an sepsis-induced coagulopathy score greater than 4, there was a mortality benefit in patients who received a heparin. But again, this was a challenging study to evaluate in many ways, given the lack of control group and the potential for multiple confounding variables and other therapies that were implemented at the time. Next slide, please. This was another case study that was published of 3 patients who were admitted and had stroke while admitted with COVID-19. They had had some antiphospholipid serology checked, and it was suggested perhaps that there was an association between COVID-19 and antiphospholipid antibodies. There are some barriers to the interpretation of this study. The serology for antiphospholipid antibodies would not be considered significant by a typical Sapporo criteria. Specifically, these patients were all negative for the lupus anticoagulant. The anticardiolipin was IgA, not IgG, and the IgA is not typically associated with thrombotic risk. And the beta-2 glycoprotein 1 was variably reported as well. So there really is no established association between COVID and antiphospholipid antibodies or stroke that we know of at the moment. Next slide, please. So this is another contentious issue, is how to diagnose VTE if you can't do a CT pulmonary angiogram for any number of reasons, whether the patient's isolated, whether the patient's too unstable, whether prone positioning for ventilation is really makes imaging challenging. The first thing to comment on would be that as per a paper in the journal from the American Journal of Cardiology recently, patients with elevated D-dimers, it's very common in COVID-19, but this does not in and of itself necessarily warrant routine investigations for acute VTE in the absence of clinical manifestations and other supporting investigations. If CTPA or a VQ scan cannot be performed, then again you rely on clinical suspicion, looking at evidence of disproportionate hypoxemia, unexplained RV dysfunction, looking into traditional VTE risk factors like active cancer and a previous thrombosis history, and then also relying on the alternative modalities listed below. This would be consideration for a bedside echocardiogram to look for RV dysfunction or rarely clot in transit, bilateral compression leg ultrasound, or point of care ultrasound. But again, there are limitations with these testing modalities as you would be aware of. Next slide, please. So this really begs one of these questions, which is, should one give therapeutic anticoagulation in the absence of objective confirmation of VTE diagnosis? This is very controversial, and at the moment, the guidelines that have been presented are giving somewhat mixed guidance about what to do. So again, the first thing would be, if there is a rapid change in D-dimer, this is not necessarily diagnostic or specific for VTE, and that alternative reasons for why the D-dimer is elevated, including infection, renal failure, other changes in clinical status should be ruled out, because the D-dimer, again, is not specific for VTE. ASH would suggest that one could consider empiric therapeutic anticoagulation if there was an unexpected clinical deterioration despite overall improvement in inflammatory markers and chest imaging, or if there are other physical examination findings consistent with thrombosis. This would be superficial vein thrombosis, calf swelling, line-related VTE, or evidence of microvascular ischemia. The ACC and ISTH put out this statement in JACC last week. They suggested that the optimal dosing for empiric treatment is really unknown at this point. The majority of panel members, in the absence of objective VTE diagnosis confirmation, would use prophylactic anticoagulation, but a significant minority did consider intermediate or therapeutic dosing, and this is an area of ongoing investigation at this time. Next slide, please. So what practical recommendations can we provide? Some institutions do have protocols that have started using intermediate or therapeutic empiric dosing of low molecular weight heparin in patients with an elevated D-dimer or patients who are in the ICU. Again, these are currently lacking in supporting data, and the challenge with these empiric regimens is that we don't know if they're even effective or if they'll change natural history. And as we escalate doses in patients who have coagulopathy, there is the real risk of increasing the risk of bleeding. We just don't know. So again, we come back to this recommendation that we generally would not recommend these empiric escalated doses outside of the clinical trial setting. We can say that in patients admitted to hospital, ward or ICU, regardless of the D-dimer, if they have COVID, they should receive standard low molecular weight heparin prophylaxis with consideration of a dose adjustment of these patients. The dose adjustment that will be recommended will vary based on institution, and the evidence for dose adjustment with different formulations of low molecular weight heparin is also limited. Next slide, please. This is interim guidance from the ISTH. They would suggest that on admission to hospital, the patient should have a D-dimer, prothrombin time, platelet count, and fibrinogen checked. And then patients should generally receive standard prophylactic doses of low molecular weight heparin. There are some controversial targets for transfusion around platelet count and fibrinogen, especially in non-bleeding patients. These are not evidence-based, and we do really have to be careful about the usage of blood bank resources at this time. Next slide, please. A couple other points that I just wanted to highlight that are quite practical from this paper from JACC from 2020. They do comment on what to do for inpatient anticoagulant management in patients without DIC. We've already talked about this. Generally, standard prophylaxis doses or IPCs if anticoagulation is contraindicated. Again, we do not recommend ultrasound screening in patients who are asymptomatic, even in spite of an elevated D-dimer. There was another study just published about 6 hours ago from France where they did do ultrasound screening in all patients, and some of these patients had even intermediate or therapeutic doses. There was a high incidence of VTE or prevalence of VTE in these patients, but again, in these small observational cohorts that are not randomized in any way, it's hard to know what to make of that data, other than the fact that these patients do have a higher incidence of VTE. In patients who do have DIC who are hospitalized, a prophylactic dose anticoagulation is still reasonable. If they are on full dose chronic anticoagulation and there is evidence of DIC, we would consider a potential for dose reduction, but this would really depend on the thrombotic risk. Next slide, please. Post-discharge prophylaxis, there have been many questions that have been posed about this recently in patients who have been hospitalized with moderate to severe COVID. We would not offer this routinely. There is evidence in medical inpatients for the use of post-discharge pharmacological prophylaxis in patients who have certain risk factors, but there are challenges with this, and in some cases, these studies have been shown with an increase in the risk of bleeding, depending on which study you look at. So it's not routinely recommended, but one would want to take the bleeding and thrombotic risk factors into account and encourage ambulation and physical activity. Homebound patients who have VTE risk factors, this is again an evidence-free area. We would consider pharmacological prophylaxis on a case-by-case basis, particularly in patients with high thrombotic risk and also patients who are looking at their bleeding risk factors, obviously. Next slide, please. So just to finish up, just to reiterate, hypercoagulable state, elevated D-dimers are non-specific. And again, just like 2 weeks ago, insufficient data to recommend anything outside of the usual standard prophylaxis with consideration for weight adjustment. Thank you.
Thank you very much, Eric. That was a tremendous summary of the data that is so rapidly evolving. We're going to move on a little bit and talk a little bit about management of thrombosis remotely. For that, we've got Deepa Suryanarayan, who is a hematologist and a clinical associate professor in the Division of Hematology and Hematologic Malignancies at the University of Calgary and a staff physician at the Foothills Hospital. Deepa?
Okay, here we go. Thanks, Alan, and I hope everybody can hear me now. So good afternoon, and thanks for everyone for coming back to the updated webinar. As we know, we are navigating through a rapidly changing landscape, so it's important to keep ourselves updated on what's been coming our way as hematologists and as well as primary care physicians. So my focus is still on going to be talking about thrombosis patients who require, of course, ongoing anticoagulation remotely in the COVID era. And this still remains a pertinent part as we play our role as caring physicians for these patients. And so most of these would be at this point of time considered, adopted standard of care that we are providing for our patients. But I will be providing a small more details on the other aspects of DOACs. The unique challenges and considerations, of course, as Alan and the rest of the panel members have alluded, at this point of time, it still remains pertinent that we have a responsibility to ensure that we continue to provide the anticoagulant care for our patients, and we do not contribute to the burden on the healthcare system if we can, and try to keep the patients on anticoagulants as safe as possible and avoid unnecessary hospital admissions. Certainly, COVID has change the way we deliver anticoagulation therapy, and I'm being blown away by but when I see all my colleagues and rest of the physicians step up to this and provide excellent care despite being in a pandemic. Next slide. Of course, the categories of patients that I'm going to be talking about still remains the same as the previous webinar, that the patients requiring initiation of oral anticoagulation. What about the patients who are already on anticoagulation, specifically with DOACs, and patients already on anticoagulation with warfarin, which my other colleague will touch upon. Next. So patient requiring initiation of oral anticoagulation therapy, again, I think there is increased onus on the clinicians in primary care to ideally initiate them as an outpatient. And certainly now there is established availability by telehealth or phone for any of the hematologists or thrombosis specialists if you need any necessary guidance in that. And certainly we are, as physicians and hematologists, we have moved to remote consultations to initiate anticoagulation therapy. The only challenge still continues that I have experienced now that I have been doing the remote consultations myself, is it is a challenge sometimes when you don't physically are able to see the patient and estimate the extent of their symptoms. And we also, my experience has been that the remote consultations are also more challenging even for the patients themselves. So we have to continuously make that effort. Where possible, yes, still the way to initiate would be to consider keeping them on or initiating DOACs where possible to minimize the interaction and risk of exposure to our patients and to minimize monitoring. For patients who are not candidates for DOACs, that has still been the consideration to start them on low molecular weight heparin, and we have been able to do that in our institutions, and certainly, especially if the patients are cancer-associated VTEs. The next slide. Of course, if warfarin is the only choice and monitoring is not possible, again, we recommend considering low molecular weight heparin for a brief period with modifications for monitoring. It has been a challenge to provide prescriptions for 90 days, but at this point of time, a lot of the pharmacies are able to provide them at the 30-day. But I usually provide them at least adequate refills where possible with electronic prescription to keep their care ongoing. Local pharmacies, again, have been made aware of the likely increased usage of DOACs, and at least in the province of Alberta, we have been told that there is enough supply, but this is something to keep in consideration as the situation continues to evolve with COVID. Next. Again, patients already on anticoagulation, especially with the DOAC, certainly always reevaluate, is anticoagulation still required in these patients? Utilize as much options that are now out there in terms of remote monitoring, such as telephone visits, video and telephone visits for follow-ups, and continue to inquire about bleeding symptoms, checking adherence, and any potential drug interactions with these with the patients. We are trying to avoid as much repeat labs as possible, especially if they have been previously stable at this time. Next. Encourage patients to avoid presenting to the emergency room for minor bleeding issues, because this is an ongoing concern as well. And most of the patients have been very receptive to the advice that I have been able to provide them through the phone support. And of course, the Michigan Anticoagulation Quality Improvement Initiative, again, is another online resource which I have forwarded to the patients just to manage any of the common minor bleeding issues at home. Next. This is another important topic. Patients on chronic anticoagulation, if they do get diagnosed with the mild form of COVID, we still have to keep in mind the atypical presentations of COVID, which again, our knowledge in this area, it continues to evolve. But we have seen presentations with GI involvement with diarrhea, and which can lead to decreased oral intake, which will play a role in drug levels, especially with the INR management, and as well as absorption with DOACs. Next. What about the concerns if the patient is on chronic anticoagulation and develops a severe form of COVID-19 and ends up being in the ICU and has been on a direct oral anticoagulant agent? Certainly, we know that these patients, especially based on Dr. Sang's previous talk, that they are hypercoagulable. There are other things thrown into this mix as well, including the use of multiple therapeutic agents that these patients will likely be started on or go on clinical trials. So among these array of therapeutic agents, this includes the antivirals, humanized monoclonal antibody against the IL-6, hydroxychloroquine, steroids, NSAIDs, antibiotics, and other immunosuppressive agents. Is a huge potential for a drug-drug interaction in this setting, especially when it comes to antivirals, the lopinavir and ritonavir. We do have data that they do inhibit the CYP3A4 metabolism based on their pharmacokinetics and dynamics. So they have the potential to interact with the DOAC. And remdesivir as well also reportedly it's an inducer of CYP3A4. And hence, given this setting, I think it is very imperative to think about these options, these interactions that may pose a hazard in keeping the patient on a DOAC. In addition to that, we know that there are metabolic alterations induced by the acute disease itself. There is potential multi-organ dysfunction with the development of liver dysfunction and renal failure, which will pose a challenge to keep them on a DOAC. Concurrent, of course, functional coagulation derangements continue to be an issue, and there is a huge possible necessity for mechanical ventilation or transfer to ICU. All of this in general will lead to unpredictable, unstable direct oral anticoagulant effects. Next slide. Hence, given the absence of any guided clinical trial, the pragmatic approach in this setting would be that we continue to balance our high thrombotic risk in these patients with the bleeding risk. The specific DOAC plasma levels have been suggested as one alternative, but they are not commonly available at all centers and not in a timely manner to help guide treatment decisions, because these patients tend to acutely deteriorate. So the recommendations would be to consider switching to a therapeutic low molecular weight heparin or an unfractionated heparin, especially if they are, there is any clinical deterioration on admission to the hospital with multiple investigational therapies also thrown into the mix. So that's pretty much my section. I will hand it over to next Sudeep.
Thank you very much, Deepa, for that beautiful presentation. Our next talk is going to be from Sudeep Shivakumar on the topic of managing anticoagulants remotely from a hematologist perspective. Sudeep is a hematologist. He's the interim division head, and he is an associate professor of medicine at Dalhousie University. He is a staff physician at the Queen Elizabeth II Health Sciences Center in Halifax. He's also the chair of Fellowship and Training Committee at Thrombosis Canada. Sudeep?
Thank you, Alan, and thank you to everyone for attending. And I'd like to follow on the previous presentation by focusing on the outpatient management of specifically warfarin. Next slide. So as everybody knows, warfarin management requires frequent blood work for INR monitoring, and that's a particularly difficult thing right now, as many patients are worried about the risk of getting blood work. It does require a trip outside the house, and it does require or bring up concerns about waiting for a blood test in an area with a large amount of people, potentially sick people. Monitoring for warfarin has to be a balance between the risk of being on warfarin without monitoring versus going out and getting blood work. And really this comes down to a risk of bleeding versus a risk of thrombosis. I think one thing that we can look to for some peace of mind is that in some of the perioperative anticoagulation studies, looking at patients with atrial fibrillation where they have to come off the warfarin for 5 days prior to their procedure or surgery, the risk of thrombosis, the absolute risk of thrombosis is actually quite low. Not zero, but quite low. So that is reassuring. So in terms of getting blood work, are there ways that we can mitigate all this blood work that is needed for managing a patient on warfarin? So the first suggestion is to move to less frequent INR draws. And there are no specific rules about this, but it is generally felt that, you know, if a patient is on a stable dose of warfarin with a therapeutic INR with no complications, it would be reasonable, especially during this time, to increase the INR frequency to every 8 to 12 weeks instead of monthly INRs or more frequent INRs. And this may be especially appropriate for patients who have a lower thrombotic risk. So those who have DVT or PE that is not in the acute period, so over 1 to 3 months old, atrial fibrillation with a lower CHAD score, or the low risk mechanical aortic valves. As well, some labs across Canada are using techniques to minimize contact and patient exposures at their labs. Some are using time tickets, so appointments, book times to get their blood work. Some labs are actually having patients wait in their car until it's time for their test and then having the test done. And Quebec has community health centers that are designed to expedite the laboratory process. As well, it is a good time to consider alternate ways of monitoring the INR. Point-of-care machines are a handy way to monitor the INR without having to go get your blood work drawn at a lab. Some pharmacies have point-of-care machines, and some provinces have programs where a pharmacist can check the INR and adjust the dose of the warfarin, which obviates the need for going to the lab for blood work. As well, purchasing a point-of-care machine is an option for some patients. The machines are a few $100s, but the test strips can be quite expensive. However, this is not covered by most provincial pharmacare programs, so it just may be appropriate for selected patients, but something to consider. And another way to mitigate the difficulties with warfarin is to consider switching to direct oral anticoagulants in the appropriate patients, after a careful discussion of the risks and benefits of these drugs. DOACs are approved for the management of DVT and PE, as well as stroke prevention and atrial fibrillation in Canada, and there is no routine lab monitoring that is needed for these drugs. Rivaroxaban and apixaban, two of the factor Xa inhibitors, can be used to treat a DVT or PE without a low molecular weight heparin run-in period, so they can be started on the oral medication from day one. Provincial pharmacare programs can be a barrier to the use of these drugs. Unofficially, some provinces are making exceptions for coverage during this time. I know that in my province, Nova Scotia, if COVID-19 is used as a justification, pharmacare on a case-by-case basis may approve the use of DOACs for a short period, a 3-month period, just to help reduce the blood work that is required with warfarin. Finally, I did want to just talk about managing anticoagulants remotely, as we are in an era of seeing patients virtually as opposed to in person. And the first thing I'd like to mention is that with anticoagulants, the risk of bleeding is definitely not zero, but it is less than 2% per year. And we are checking in on patients by phone or Zoom or other platforms. And it's important to ask about things like bleeding complications, compliance with the medication, and any side effects, of course, that they've had. And it's also important to just be aware of any drug-to-drug interactions, especially with any new medications or antibiotics that they may have started. And I would like to mention that, you know, a high INR is a frequent call from the lab to healthcare providers, but a high INR in warfarin can often be managed by holding the warfarin alone without any additional measures if the INR is less than 10 and there's no bleeding. The CHEST guidelines, the American College of Chest Physicians guidelines, can be used as a guide for this. So I hope I've been able to give some practical considerations. Thank you for your time, and I'll be turning it over to Dr. Lane.
So thank you very much. Excellent talk, Sudeep. Very practical information for my colleagues in primary care and other generalists. Our next talk is truly from the front lines of COVID-19, and that is the emergency room. So Dr. Eddie Lang is professor and department head for emergency medicine at the Cummings School of Medicine at the University of Alberta. He is the scientific director of Emergency Strategic Clinical Network in Calgary, and he is co-chair of the social media committee at Thrombosis Canada. So what's happening on the front lines there, Eddie?
Thanks, Alan. Great to be here. And you know, there are many front lines in this battle around COVID, so I certainly want to recognize all of my colleagues in primary care and in urgent care that are putting themselves at risk every day with so many challenges. So what I'm going to do is build on the presentation that I gave a couple of weeks ago and talk about what I think is, from a VTE perspective, probably one of the most worrisome issues for emergency care, which is that people are avoiding the emergency department for serious conditions, likely due to the fear of COVID infection. And I'm going to show you some data that may be pointing in that direction. I also want to share with you some of the updated modeling that you may have seen on the news that we're seeing here in the Alberta context, which is certainly creating some tensions now around hospital reopening. And then just let you know what are our priorities in the emergency department. Here's a story from St. Paul's in Vancouver, but it's not just St. Paul's. All Calgary hospital emergency volumes are down 35 to 40%. This is even occurring in contexts like the UK and France, which were hit very hard with COVID. I mean, certainly their COVID business or their COVID patients are taking up a lot of effort, but it's amazing how the non-COVID patients have gone down. And this is reflected not just with lower acuity visits in the emergency department, but also with reduced EMS transports and reduced hospitalizations. Here's some worrisome data offered by the Office for National Science in the UK, reporting this concept of unexplained excess mortality. So the number of deaths recorded in the countries that have been hit hardest by COVID are several thousand greater than the number of COVID-specific deaths. The actual explanation for this is not complete yet. One possibility is that these are actually COVID deaths, but because they've occurred in home settings or in nursing home settings and they have not been accompanied by a positive COVID swab, maybe they are being represented as non-COVID, but when in fact they actually are. More worrisome though, and I think this is important for all of us to communicate to our patients, some of this could represent delayed presentations for heart attacks, strokes, and of course other thrombotic entities like venous thromboembolism and pulmonary embolism that are just not coming to hospital because people are afraid that they're going to catch the virus by coming to the emergency. So we're still awaiting some population data on the harms. There have been lots of anecdotal stories of people coming to the emergency department with ruptured appendix and MIs that are well beyond the treatment windows. And what we're doing here in Calgary, at least, is we're using our safety system to encourage people to complete safety reports when one of these occurs so that we have a better handle on what's going on. But it's still hard to fathom that most places are, for example, reporting a 40% reduction in STEMI activations, which is certainly very disconcerting. One thing that we have to say is that when people do come to see us, it's often for now a very clearly bona fide reason. And what we're looking at this data currently, but it seems that many of the imaging studies that we're asking for, rather than seeing a 10 or 15% yield of positivity, we're seeing much higher rule-in rates, suggesting that the people that are coming to our door do have this internal feeling that something is seriously wrong with them, and they often rule in for important disease. Also want people to keep in mind that there could be some benefits for the health impact on the population. We've eradicated influenza, Norwalk, adenovirus to even a large degree because of the physical distancing. Trauma is down significantly because of the closure because of reduced traffic and some of the trauma that's related to bars and restaurants that we do see in some of the urban settings. This is confirmed by police reports, has been down as well, as including, and for VTE, some of the post-operative phenomenon that we often were managing in the emergency department are down as well. So I think the main thing we're concerned about is this concept of collateral damage. Not only the psychological and economic impacts that are certainly coming down the road as a result of the confinement and the public health measures, but even the collateral damage that's occurring right now related to patients avoiding the hospital. So as you might have gathered, the initial models predicting the peak in ICU and inpatient demand have been downscaled considerably, and that's largely because there's now real data to inform the trajectories. And I think it's generally true across the country that the initial estimates for inpatient care and ICU care have been overstated perhaps by as much as a factor of 4 or 5. And as a result, we remain in many jurisdictions with thousands of canceled elective surgeries and probably quite a bit of suffering and anxiety in the community, delayed imaging. The wait times and the waiting lists for imaging and surgery have exceeded reasonable amounts, with thousands of cases waiting, and it's going to be very difficult to catch up with all of this demand, especially if you think about all of the unused capacity that exists currently. So what we're struggling with locally, and I imagine we're not alone, is we're asking ourselves are we in this kind of grumbling, low-grade dance with the pandemic? Currently we have only 40 patients in hospital with COVID across a city that serves a population of 1.5 million, with hundreds of empty beds. And as you can imagine, there is some tension and some demand, some requests, a very reasonable one coming from our surgical colleagues, to start opening up the hospital again and to at least allow some elective surgeries to occur. So what we're thinking about mostly, of course, still in the emergency department, is the PPE situation. This is widespread throughout our healthcare system, but as we're now routinely wearing masks for all patient encounters, and in some instances masking patients, our burn rate for PPE is 4 or 5 times what it normally is, and is creating some supply chain challenges that are worrying our senior leaders. When it comes to managing respiratory distress and failure, what we're increasingly learning is that a lot of these patients are demonstrating hypoxia without necessarily significant symptomatology or dyspnea for that matter. And we're looking at some of the data on the utility and the impact of intubation and the outcomes of especially the elderly who are in the ICU and intubated, and trying as much as possible to use intubation in avoidance strategy, which includes allowing permissive hypoxia if in fact the patient is comfortable and has good nasal flow, oxygen, as well as proning the patient to improve oxygen delivery. We're doing palliative care in the emergency department as never before, as we are still receiving patients with very guarded prognosis, not likely to be candidates for intubation or critical care, and some very severe decision-making and symptom control is happening at the emergency department, but maybe less so because we're also communicating in a far more collaborative way than we ever have from the emergency department with EMS and our long-term care hospitals in order to potentially prevent unnecessary transports and do palliative care on site. We're now really in the business of trying to monitor outbreak surveillance. As you might know, in Alberta, the key issues are related to the meatpacking plants and some of the fallout related to the difficult social conditions, the language barriers, and some of the housing arrangements of some of the workers that have been in these settings. And as a result, we're seeing wildfire-type outbreaks occurring in these communities. And as I mentioned earlier, we are following safety standards to report these adverse outcomes so that we can better understand it and better communicate the risk to the community. So thanks so much again for your attention. Stay safe and be healthy, and happy to answer any emergency-oriented questions or anything that might be VTE specific to the ER. Thank you.
Well, thanks very much, Eddie. That's a fascinating talk. Who would have guessed that COVID-19 would result in collateral damage due to underutilization of the emergency rooms? It's really fascinating. So all of the questions that have been posted during this session will be responded to on the Thrombosis Canada website, the dedicated COVID-19 area. I want to remind all of the participants that we are running another program on Wednesday, April 29th. It's going to be a little bit different from this one. It is going to be a primary care perspective of thrombotic issues in COVID-19. You can go to the Thrombosis Canada website to register for this meeting, and I would encourage you to do so. I think it's going to be very happy. It's going to be an excellent presentation, not only for primary care physicians, but also for pharmacists, for nurses and nurse practitioners, and really all healthcare professionals. We want to thank you all for attending today, for your commitment to lifetime learning in medical education. Yes, I would also like to thank all of our sponsors for this program. So I'd like to thank Bayer Canada. I would like to thank BMS Pfizer Alliance. I would like to thank Leo Pharma. I would like to thank Novartis Pharmaceuticals Canada, Pfizer Canada, and Servier Canada for their support, completely unrestricted support of this program, which made it all possible. So with that, I wish you all good afternoon, and thank you for attending.